All right. Well, good evening, everyone, and welcome to this week's continuing education webinar. Here at Zomedica, we are so glad you took the time out of your day to join us. We are excited to be talking about acute non-traumatic spontaneous hemoperitoneum in dogs. It is being presented this evening by Dr. Shadi Arifich. Dr. Shadi Irfich graduated from the State University of New York at Binghamton, where he received his Bachelor of Science degree in biology in 2001, magna cum laude. He then attended Cornell University, where he received his Doctor of Veterinary Medicine degree in 2006. And after completing his studies at Cornell, Dr. Irfich participated in an intense 1 year small animal medicine and surgery rotating internship at Angel Animal Medical Center in Boston in 2007, followed by two rigorous 1 year small animal surgical internships at Long Island Veterinary Specialists in Plainview, New York. He achieved his board certification in small animal surgery by completing a 3 year small animal surgery residency at LIVS in 2012 and subsequently became a diplomat for the American College of Veterinary Surgeons. He then later transplanted to Las Vegas, Nevada in 2016, where he became a staff surgeon at Las Vegas Veterinary Specialty Center. And in 2018, he joined True Care for Pets in Los Angeles, California, as chief of specialty. In 2020, Dr. Arifich changed gears in his already illustrious career, finding a novel and state-of-the-art means of reaching concerned pet owners and their ill pets worldwide: vet triage. Dr. Arifich currently serves as their chief medical officer. He's been published in scientific and medical journals and enjoys lecturing to a variety of audiences. He's known for being a positive force and energetic force both professionally and personally. So without further ado, please join me as we welcome Dr. Shadi Arifich.
Thank you so much. Thanks everybody for taking time out of your evening to watch and listen to this. I am Dr. Arifich, acute non-traumatic spontaneous hemoperitoneum in dogs. The proceedings that you may already have or that you should receive from Zomedica are very detailed proceedings that include the latest literature. So that has way more nuance, way more detail than we're going to review over in this webinar. This webinar is intended to be very practical, very clinical, hopefully useful information for folks who deal with hemoabdomen. So please reference that proceedings, as it'll have way more detail than we'll go into here. Thank you, Zomedica, for sponsoring this event. It's always a pleasure to be here. And even with the title, Acute Non-Traumatic Spontaneous Hemoperitoneum, I've changed that title from previous webinars because the current medical literature uses that phrase to describe hemoabdomen in animals that are not related to trauma. However, you could also have coagulopathies, so it's not always like a splenic mass, which will be our focus for this talk. But just keep that in mind, that even that title doesn't really encompass everything, but it is what the current literature uses, so that's what I've used for the title. Those of you who already heard about me, so that's my background there. And this is the outline we're going to follow through here. A lot of information, but again, your proceedings will go into way more detail, and we'll spend a little bit of time on each of these topics here and give you a better understanding of hemoabdomen from a board-certified surgeon's point of view. So the anatomy of the spleen, we are all familiar or should be familiar with the anatomy. It's in the abdominal cavity, the left side of the patient, sitting right by the stomach and overlying the kidney and being hugged by the liver. And then the vascular supply of the spleen, of course, is vital, especially if you're going to perform splenectomies. So what you care about as far as a splenectomy goes is its vascular supply. And keep in mind, when you're removing a spleen, especially for a splenic mass, you're not necessarily aiming for margins. You're trying to hug as much of the spleen as possible so you can stay really close to the spleen, and that way you avoid all the important vasculature to the stomach and especially to the pancreas. So the goal with surgery is not to gain margins in this respect. You're trying to simply remove the spleen and literally hug the ventral portion of the spleen when you're trying to remove it, and that's the importance of learning the anatomy. Those of you who have performed this surgery or have performed splenic mass removals in dogs with large masses, with adhesions, hemoabdomens, will know that a lot of this anatomy becomes distorted, and so your main focus is to stay alongside the spleen when you're trying to perform a splenectomy. But it's important to know the normal anatomy, although a lot of the normal anatomy may not be present for an acute hemoabdomen. But there are also cases where you're removing a spleen with a non-hemoabdomen situation. You found a splenic mass on ultrasound and you've scheduled a splenectomy at your facility. So the anatomy there will be much more clear in that type of scenario. And then the histopathologic anatomy of the spleen, also very important. The proceedings you have will go into a lot of the functions of the spleen, including its gross and histonomic anatomy there. But we're all familiar with the spleen having very important functions regarding to red blood cell storage and production and release, as well as a vital part of the immune system. If anybody knows a person who has lost a spleen, they are chronically, lifelong, have immunodeficiencies. We don't see that as much with animals that have lost a spleen, but in human beings it's quite debilitating. But the point is to remember that the spleen does function for immunosurveillance, antigens, releasing of immune bodies, things like that. Very important part of the immune system, and your proceedings goes into those types of details. Now, to get into the incidence, when you read the literature, the numbers are all over the place. It depends on how any given paper will characterize these percentages. So you may read one paper that has nuances to it that may not seem so clear on a slide like this. Your proceedings have more detailed instances, but we'll go over here in general just to give you an idea of the prevalence of this disease. So as far as splenic masses in our dogs, they make up 0.3 to 2% of all cancers in dogs over 8 years of age. They make up 5% of all non-skin primary malignant cancers in large breed dogs. And the number of neoplastic incidences of the spleen in dogs can range between 33 and 76%. That's a massive, massive scale. And so a lot of it depends on how they're counting these cases in any particular study. So you may read a paper and say, oh, that's not very high. I thought it was higher. I was taught that it was higher. And you may read another paper where it's like, wow, 3/4 of dogs with splenic masses have cancer. Then stromal sarcomas make up about 2.5%, unclassified 0.4%. Non-neoplastic can range from 1/4 of dogs to half of dogs. The number of cases that you see with a rupture when they have a benign splenic tumor is about 26%. So we do tend to see a hemoabdomen as a predictive value when trying to figure out if this is going to be cancer or not. That doesn't mean that every hemoabdomen is cancer, but it does kind of hint you in that direction if there's a hemoabdomen there, as they are more likely to rupture. Overall malignant incidence, 64 to 80%. Overall benign, 10 to 35%. Again, a lot of overlap, really wide ranges, and that's because the literature is all over the place, but at least it gives you a sense. What you can take away from this is, generally speaking, cancer is way more prevalent in dogs, in older dogs that are large breed with splenic masses than they are benign. So that's kind of the overall takeaway, but it's not a death sentence. There's still a chance of benign disease, and that's the other point to make. And there is a study that I quoted in the proceedings with small breed dogs. Miniature schnauzers, dachshunds, beagles were overrepresented. Hemoabdomen, 31% of these dogs. Malignancy in 66%. When you look at the cancers, 27% made up splenic hemangiosarcoma, but there are other splenic masses that are malignant. And then non-neoplastic splenic cases, splenic masses rather, 44% of cases in small breed dogs. So I have cut a handful of small breed dogs with splenic masses and hemoabdomen in my career. They are not common at all, but don't ever assume just based on breed that they can't have a splenic mass as a cause of hemoabdomen. So overall malignancies, in dogs, up towards 80%, so about 3/4, and that's kind of the general rule that we use. And the majority of those cancers are going to be hemangiosarcoma, and also in the majority of these cases, hemangiosarcoma will be the source of the bleeding. The hepatic hemangiosarcoma cases make up 30%, omental 15%. Metastatic disease to liver, about 30% of cases. Other malignant tumors can be seen in 8 to 43% of cases. Benign growths, 10 to 35% of cases. And then splenic hemangiosarcoma with a hemoperitoneum, like I mentioned before, that's the majority of them are going to be hemoabdomens. Splenic hematoma with hemoperitoneum is about 1/3. And these are important for owner discussions. So when you have these frank conversations about them trying to decide whether or not they want to invest in surgery, certainly it seems that the majority of hemoabdomens are going to be malignant, but it's not 100%. There's still a chance for benign disease. And then as a reminder, of course, there are many other malignancies you can diagnose, not just hemangiosarcoma. Some of these I have diagnosed in my own career, but there are many other cancers that can cause splenic mass or hemoabdomen associated with a splenic mass in dogs. So keep that in mind as well. So hemangiosarcoma is, of course, the focus, and just in brief, it is a malignancy of vascular endothelial origin. It's known for widespread metastatic disease and a poor survival. I have a list there of all the primary sites. Spleen, of course, is the most common, but there are other primary sites for hemangiosarcoma. And then metastatic. When you look at liver, omental, and mesentery metastatic disease, that makes up 62.5%, at least based on a necropsy paper, but you can see metastasis anywhere in the body, which makes sense. It is a vascular tumor, and therefore anywhere that has blood vessels is prone to metastatic lesions for hemangiosarcoma. I do want to talk specifically about cardiac because I'm not sure it does get enough attention. So cardiac or right atrial hemangiosarcoma is something that we do see in animals, whether it be primary or metastatic. And when you look at cardiac hemangiosarcoma in association with splenic hemangiosarcoma, it can make up between 8.7 and 30% of cases. German Shepherds are at increased risk. They make up 70%. Golden Retrievers, 11 times risk of having a cardiac tumor. And then when you look at cases that have both a cardiac tumor as well as abdominal metastatic disease, that makes up a third of those cases. So my questions or thoughts on this revolve around emergency surgery. For those of you who have cut hemoabdomens in the middle of the night, you're typically not going to have access to an echocardiogram, as it shows in the picture here. This picture shows pericardial effusion and then an auricular mass. But even if you have thoracic radiographs, which we'll review later, you might see evidence of pericardial tamponade, but otherwise a small amount of pericardial effusion may not be obvious on a 3-view metastatic screening with thoracic radiographs preoperatively. And of course, you're cutting this dog in the middle of the night because if we don't stop the bleeding, the patient's going to perish. So we a lot of times sort of do a cursory examination of the heart through auscultation and 3-view thoracic radiographs, but then we roll them right into surgery and perform the exploratory laparotomy. So we don't know necessarily how many dogs have cardiac disease associated with the mass, and they're just not clinical for it. How many of them develop signs of pericardial effusion or tamponade later on, and after having a splenectomy for hemangiosarcoma, and the question is, was that cardiac mass there at the time of surgery? Not sure. And of course, expecting veterinarians to have an echocardiogram performed in the middle of the night, probably unlikely. You might have an emergency doctor that's proficient with ultrasound and can find a cardiac mass, but otherwise, that's again typically not the norm, especially in the middle of the night. So I just bring this to everybody's attention to realize that there may be some level of disease that may have precluded that case to go into surgery if the owner had known there was a cardiac mass, but I just don't know if we think about it that much. That being said, it still is a low incidence, so it's not like it's that big of an ordeal, but just keep that in mind as well, that it is something to at least mention to pet owners about. So the idiopathogenesis of this condition involves around oxygen transport or lack thereof. You see a decrease in circulatory red blood cell volume because of the hemoabdomen and blood loss. It affects the circulating cells, causes restrictive lung disease, especially if the diaphragm is being pushed cranially due to a hemoabdomen, or if you have metastatic disease in the thoracic cavity. Anemia, of course, contributes to all of this. And then I will say end stage, but not necessarily. You risk coagulopathy with these animals, and this is associated with mass rupture and can result in hypotension, hypoxemia, and ischemia. And DIC is seen in 12% of solid malignant tumors, and an increased rate with hemangiosarcoma. Of course, DIC is a prognostic factor here with these cases, so you can see the chain of events here can become very severe and life-threatening, and it's not unusual to know why these dogs come in pretty much in hemorrhagic shock. So the World Health Organization characterizes splenic masses in this way. We don't use this as much, I find, in veterinary medicine, but just so you're aware and how to sort of categorize these diseases, because obviously a stage 3, you'd presume, has a worse prognosis, which it does. But stage 1 involves primary tumor, localized disease. Stage 2, primary tumor with either lymph node involvement or you have a ruptured splenic mass. And then we do tend to see stage 1 and 2 most often. That makes up 50 to 75% of dogs. Stage 3 is metastatic disease with a splenic rupture or lymph node involvement. And so we should, in theory, with our medical records, try and categorize them based on stages, as it is a bit more thorough. Signalment, mean age of 10 years old, usually large breed to giant breed dogs, golden retrievers, German shepherds, Rhodesian ridgebacks, Labradors. These are dogs that are predisposed. Clinical signs, of course, associated with hemorrhagic shock, weakness, lethargy, abdominal distension, tachycardia, tachypnea, pallor, weight loss, collapse. And so, I have had cases that I believe are a bit more acute on chronic, meaning that they've had a splenic mass with no clinical signs, and then the owner, if you really drill the owner and quiz them on the history, you'll find that this dog may actually have had bouts of lethargy and weakness in the past, and that sort of self-resolved, and they thought, well, maybe my dog's old, maybe flare-up of arthritis or whatever it is, just off that day. And I'm convinced, I can't prove it, but I'm convinced that some of these dogs develop an acute hemoabdomen, the body seals it up, and so once the body seals it up, those clinical signs quickly go away, and then you have a normal dog again for the next few weeks or months, and then it happens again. And so I'm convinced that these dogs have perhaps microhemorrhages or localized hemorrhages where the omentum can latch on to that ruptured splenic mass and then stop the bleeding, and then we're back to normal again. So I wonder about that as well. Don't discount a chronic history of waxing and waning signs in an acute, non-traumatic spontaneous hemoabdomen. Diagnostics, your proceedings go into way more detail. Just going to highlight some points here. You're going to perform a chemistry panel. There are coagulation panels, biomarkers, all that's in your proceedings. The CBC is a big one because thrombocytopenia is seen in 3/4 of these dogs. And I've had these discussions with internal medicine doctors where theoretically, if there are low platelets, especially under a certain threshold, you get worried about cutting these cases because you're worried that they're coagulopathic. However, the majority of these cases, 3/4, I've cut have thrombocytopenia, and they've had no evidence of coagulopathy prior to that, and you'd expect to see signs of coagulopathy, especially with thrombocytopenia, with superficial petechia and ecchymosis. So I believe probably that the thrombocytopenia is due to the acute hemorrhage and not necessarily a coagulopathy per se. It's secondary to the bleeding. So even though thrombocytopenia is present, and if you had a spay, for example, that had thrombocytopenia, you certainly wouldn't cut that dog. You'd work up the thrombocytopenia, or if they had clinical signs of a coagulopathy on a physical, you'd work that patient up. But with hemoabdomen specifically, especially when they're in critical shape, it's an acute onset, I'm doubtful if they have a coagulopathy. This is probably more of a platelet loss due to acute hemorrhage, and the body just hasn't made up for it because it's an acute hemorrhage. So just keep that in mind if you see that as you're working up these cases. Leukocytosis, neutrophilia, those are both associated with a worse prognosis. Whether or not that's clinical or not, you have to have the talk with an owner. And then anemia, you're typically looking for non-regenerative nucleated red blood cells with schistocytes. So that's kind of the classic, although not required, but that's the classic findings on a complete blood count for a hemoabdomen. ECG, very important. Obviously, any patient that comes in with potential shock, acute collapse, pale mucous membranes, tachycardia, you'll probably have an ECG on them, electrocardiogram. We do see ventricular tachyarrhythmias in 25 to 45% of angiosarcoma cases. In terms of breaking it down, pre-op 8.4%, intra-op 16%, post-op 40%, and this is due to a variety of reasons that I have listed here. So for all these reasons, you're going to explain to the pet owner that the dog doesn't currently have ventricular arrhythmias, that they're prone to it in surgery or especially post-operatively, and it can be due to a variety of factors. So as you're trying to get the patient into the operating room, you are trying to also stabilize them so that you can prevent something like ventricular arrhythmias in these dogs. But some of these factors may be out of your control. If it's due to cardiac depressant factors from like a tumor or from a stressed viscera, stressed organ, it's hard to combat that, but we have to at least screen for it. So the electrocardiogram is very important. As you roll them into surgery, typically I've either had these dogs worked up by the emergency department before I come in to cut the case. So they've had the ECG, they've had a 3-view thoracic radiographs. Otherwise, if these haven't been performed yet, especially the radiographs, then I'm going to perform these while the patient is probably under anesthesia as I'm continuing to bolus fluids to try and go right into radiology, into the operating room to save time. I'm trying to be as efficient as possible. But every hospital will do this differently. It just depends on who's cutting the case. So plain radiographs, you're looking for any changes with cardiac silhouette. So for example, here you can see a generalized globoid heart. This is very suggestive of pericardial tamponade. Maybe it's due to a secondary systemic inflammatory response syndrome. Maybe it's due to cardiac tumor. Or maybe this is a golden retriever that has idiopathic pericarditis and just so happens to have now a hemoabdomen, maybe unrelated. But regardless, that's highly suggestive of that. You're looking for a fusion, so pericardial or pleural fusion. These lines here may be hard to see on your screens, but these lines here are showing pleural fissure lines on this patient. And so pleural fusion, again, is that because of metastatic disease? Is that because of systemic inflammatory disease, microembolic disease? Hard to say. Lymphadenopathy, specifically peripheral sternal lymphadenopathy, and then any evidence of metastatic disease before going into surgery. That helps the client make decisions if you do have those findings. Abdominal radiographs, abdominal ultrasound. It's maybe unlikely that you have access to abdominal ultrasound on an emergency basis, but these are just examples of various splenic masses. This is more of a diffuse change to the spleen. Maybe you're thinking splenic lymphoma, whereas this is more of a solid type tumor with cavities, blood-filled cavities, or at least fluid-filled cavities, I guess, in the tumor itself. That may be more of a hemangiosarcoma or something like that. And then a plain lateral thoracic or abdominal radiograph, where you can see here a splenic mass, or at least a mass in the region of the spleen. This could be liver, this could be stomach, could be lymph node, could be intestine, pancreas, etc. But it's certainly suggestive of a splenic mass or maybe a liver mass based on the location and displacement of the small intestines caudally and the stomach to some degree displaced cranially. So, and then you can argue maybe there's more of decreased serosal detail here in the region of the kidneys and dorsal abdominal cavity, maybe indicating ascites. So those are all things to look out for. There are a multitude of diagnostics that are mentioned in your proceedings. We already discussed echocardiogram. Performing a final aspirate with cytology. I've seen internal medicine doctors do it, and it's not wrong to do. Of course, you are aspirating a blood-filled organ, so a lot of times these tend to come back not either non-diagnostic or evidence of extramedullary hematopoiesis, so it may not give you much information as a surgeon as to whether or not it's cancer, but it is discussed, it is an option. CT and MRI, more so in people, or sometimes if you're performing a CT or MRI for some other reason, you may come across an incidental splenic mass. But really, at the end of the day, based on radiographs, or if you have abdominal ultrasound, you see the splenic mass, and if it's a hemoabdomen, time is of the essence. You want to go ahead and perform exploratory laparotomy. Keep in mind, histopathology, the only way, unless you have over evidence of metastatic disease, histopathology is the only way to know whether or not you're dealing with malignancy versus benign. And unfortunately, in the case of spleens, you need to remove the entire spleen in order to get the diagnosis from histopath. So keep that in mind. You could have a situation where there's a splenic mass on ultrasound and also hepatic nodules, and that could all be benign disease. You don't automatically assume that hepatic nodules means cancer. It's certainly suggestive and it's concerning, especially with an older large breed dog. But again, you don't know for sure unless you cut that case whether or not you're dealing with cancer. So this is just an example of a dog with CT scan. This is in dorsal recumbency, so the pelvic limbs are over here, and you have a mass associated with the spleen. And then this is a sagittal, or rather a transverse view of a CT scan of the thorax, and this is supposed to be pointing to a thoracic nodule. But again, MRI and CT are usually not the test of choice for these cases, especially if dealing with a hemoabdomen. We can diagnose these from radiographs or ultrasound. So predictive factors that may tell you that this is a high chance of hemangiosarcoma. By no means black and white. These are just what the literature has suggested or has found in terms of tendencies. So hypoproteinemia, thrombocytopenia, abnormal red blood cell morphology, having hemoabdomen, maybe high lactate might be predictive. We do see that benign splenic masses have a higher mean mass to splenic ratio versus hemangiosarcoma. So that ratio, if you do the math, benign is around 5 hemangiosarcoma 1.8. So that may give you a hint that you're dealing with hemangiosarcoma based on this volume ratio. But again, it can vary. I've seen very large splenic masses that are cancerous. I've seen small ones. And the benign splenic masses have a higher mean splenic weight as a percentage of body weight versus hemangiosarcoma. Again, general rules. If you had a pet owner that really wanted to figure out how do we know for sure this is cancer without going into surgery with my geriatric Great Dane, these may be hints that you're dealing with hemangiosarcoma, but of course they are not 100%. Stabilization is of course beyond the scope of this, but we can talk about it if we want to with our Q&A. But you're trying to increase the vascular volume for these dogs. So typically you're using not just one, but probably two large bore catheters, and to administer probably shock doses of fluids. If they require a transfusion, usually packed red blood cells, or if you have whole blood, sure. But otherwise, you're transfusing them as needed, and your goal is to stabilize them as quickly as possible in preparation for surgery. These are not medically managed cases. These are going to be surgical cases. So these are all of the various treatments. Now, some of these are not specific to hemoabdomens, but I just wanted to be thorough, and of course your proceedings go into more information on these. I'm going to talk about partial splenectomy right now. If you have a splenic mass in a dog, it is unethical and inappropriate to perform a partial splenectomy. You never, ever, ever remove the portion of the spleen that has a tumor and leave the rest of the spleen in there. Why is that? Because the chance of cancer is still so high in dogs that by removing only part of the spleen, you not only are ignoring that fact, but if the splenic biopsy comes back as cancer, you are now subjecting that patient to another surgery to remove the rest of the spleen. You can't get margins on a vascular malignancy, just not possible. So you remove the entire spleen. That's done 100% of the time. I've rarely seen a partial splenectomy, and it's usually due to either trauma or there was one case that had an internal abdominal hernia where a portion of the spleen lost its vascular supply, and the spleen was removed, still biopsied, because just in case, but the biopsy portion was the removed portion, and the rest of the spleen was left behind, and that pet owner was warned that if it does come back as cancer by some weird chance, then we have to go back in for the rest. But in general, those are exceptions. In general, most often, you're going to perform a complete splenectomy, no questions asked. That's the solution for this. In people, they try to perform partial splenectomies for splenic masses because the spleen is a very important part of the immune system. So you really are causing a debilitation to that person lifelong if they have no spleen. And also the ratios are different. I don't know what the percentages are, but I do know that the percent chance of having cancer in the spleen in humans is less than dogs. But for dogs, complete splenectomy. Always liver biopsy for staging purposes, or if you happen to go into surgery and you find a hepatic mass and it's easily accessible, meaning you're not going to risk the patient's well-being by performing the hepatic biopsy, you always perform the biopsy and submit that. Now the question is going to be whether or not you perform other procedures. So for example, do you pexy the dog at the same time? If this is a 9-year-old Rottweiler with a hemoabdomen and a splenic mass, it's never had a gastric dilatation involved its entire life, but you're in there now. Do you perform this procedure knowing that if the biopsy of the spleen comes back as hemangiosarcoma, the prognosis is poor? Maybe it's a month or so without chemotherapy, right? And so do you perform that or not? I don't know. Other biopsies, if this is a dog that has also bladder stones, mammary gland tumors, do you remove the tumors while you're in surgery? If they have cystoliths, they have bladder stones, do you perform a cystotomy at the same time while you're in there, even though you're in there for an emergency hemoabdomen? I don't know the right answer, but I can tell you my experience. What I do with these cases is that the pet owner really is adamant about performing other procedures while you're in there. What I tell the pet owner is I'll perform these ancillary or adjunctive procedures if and only if the patient's anesthetic and surgical stability warrants it. So I have the right to abort mission if your dog is not doing well under anesthesia. The goal is to remove the spleen, get a liver biopsy, and get out. That's the goal. If your patient is super stable and I can perform the cystotomy or whatever else, then I'll do it. But understand that there is risk with that in terms of prolonging anesthesia and surgery times. And again, I have the right to abort mission. And pet owners, of course, agree to that because they don't want to subject their pet. What's the sense of having bladder stones removed if the patient dies because of hemodynamic instability, right? That's just common sense. But you as a veterinarian, it's not wrong to perform other procedures. You need to have that frank conversation with the pet owner to say, I'll do it, but I also have the right to not do it if I feel like it's unsafe for that patient. And then chemotherapy and immunotherapy, discussed more details in your proceedings, but I only touch upon them superficially. You should seek out other sources for that information. So surgery, this is a picture of a partial splenectomy. This is a splenic laceration repair. These, of course, will not be performed with a splenic mass and hemoabdomen, but I just want to be thorough and show you what that's like, and then just a reminder of the vascular supply of the spleen. Here is all the various techniques you can use to remove a spleen. My favorite, of course, is ligature. This is almost like cheating with surgery. It's so easy, but I'm not sure if these are no longer made or if they have a different version of them now. These are expensive instruments, and you have to have a practice that is going to perform a lot of surgery. I perform these on many surgeries, nephrectomies, spays. Lots of surgeries are basically vascular surgeries in the abdomen, and so this gives you a really reliable and fast way of occluding blood supply to an organ that you're going to remove. But there are lots of other options as well, including old school just suturing pedicles. That takes a long time, of course, but that's what most folks end up doing. This is a reminder, if you have a splenic torsion, which can be seen with hemangiosarcoma, although very, very rare. If you find yourself in this position, do not unravel the spleen. You remove it and block. You remove it to the best of your ability at its base. You do not unravel this. You will release inflammatory mediators, and the patient will almost instantaneously develop lethal or life-threatening ventricular arrhythmias and have all this oxidative damage. You do not unravel the spleen. You remove it as is in its torsed position. Just a reminder. Liver biopsies, many different techniques. Again, I like to cheat by using ligature. It's so easy. What technique you use for liver biopsy really depends on your comfort level and also what part of the liver you're going to biopsy. And this sort of method here is done where you don't feel like you have a good process that you can perform the guillotine method, right? The guillotine method, I think, way easier than performing this. But if the liver is very rounded and plump, you may not have a good liver hepatic process to do this with. And so the guillotine method is the other way of doing it. There's a dermal punch biopsy that you can also perform for a liver biopsy. And then for me, instead of doing something like this where I'm going to skeletonize the vessels, instead what I will do is with my ligature, I'm going to crush the tissue using like a Carmalt or a hemostat, and then I'm going to use ligature over the vessels. The reason why I crush the tissue is because it removes the hepatic parenchyma and just leaves me the vessels there, which have a lot more resilience than the hepatic parenchyma. And so that's a nice way to transition into this product. Zomedica makes this Vetigel, and this thing is awesome. It's still very new. I haven't used it, but in reviewing the papers, the medical literature on this, and looking into it, we're seeing a lot more products like this in the profession that make it so that something like a punch biopsy, for example, instead of relying on gel foam to stop the bleeding. Gel foam has its pros and cons to it. I'm a fan of gel foam in certain scenarios, but a lot of scenarios I find it very difficult to use. Something like this, awesome. And I'll show you a video here in a little bit, but it allows for fairly rapid hemostasis, and you can use it in the body or outside the body. It's quite potent. So a variety of indications that they cite and that I can also think of for this type of hemostatic product. And the beauty about these types of things is that it actually creates its own pressure of the area, so you don't have to have manual pressure to stop the bleeding. It provides a mechanical barrier, creates ionic crosslinks. It relies on the patient fibrin to form that clot, and then you can remove it if you want to after a few seconds. In the literature, I saw a maximum number was 2 minutes for severe bleeding, so still very quick. But it also can be ingested if you use it for oral surgery and the dog happens to swallow it. And also it is absorbable. So if you do leave it in the body, no harm, no foul. Let's see if I can play this quick video. This is showing here a dermal punch biopsy in the liver. And so you can see, you can squirt this stuff on there. It's so cool. And it'll fill in the defect and start doing its thing. Because a lot of times when I see people who are performing splenectomy for the first time, they're nervous about the liver biopsy, and something like this is really, really helpful to fill up that defect and have reliable hemostasis fairly quickly. So there's another example of literally squirting the vetted gel in there to perform hemostasis. Very cool. And they've also used this for horses as well. Obviously, we're focusing on canines, but it is a pretty potent product. So I'm happy to mention that. Post-op care. I realized through doing this webinar for a number of years now that a lot of folks have questions about post-operative care. So this is assuming that you have a 24-hour hospital, maybe not always necessary, especially if you have a controlled splenic mass that's scheduled and there's no hemoabdomen, the dog is stable. They potentially could go home that same night. If you're a general practice and you want to cut the case in the morning and then monitor that case all day long, even in that scenario, you would have some resemblance of monitoring like this. But in a 24-hour facility that's going to be seeing hemoabdomens or that are going to see your case as a transfer from the general practice to the ICU, this is typically what I've done as a surgeon. You either can have electrocardiogram be continuous, which is ideal, or at least spot checking with an ECG every 6 hours, doing about a minute of a ECG and then having the doctor evaluate it. Blood pressures, again, if the patient is tolerant or if they're just recovering and you want to have continuous blood pressure monitoring, that's great. Otherwise, every 6 hours, check a blood pressure. PCV total solids checks, depends on the case, but in general, I'm typically checking it within an hour post-operatively, and then depending on the case, probably twice a day is sufficient. It all depends. If you're giving a blood transfusion, you're not going to check PCV total solids during a blood transfusion. You're probably going to check it about 4 to 6 hours after the transfusion. That's what I typically do, and then BID from there. If you're really worried about hemorrhage in surgery, like something went wrong or there's the splenic mass ruptured on you in surgery, you can have your assistant or technician check at PCV total solids in the actual intraoperatively while you're performing the procedure and see if you have to rush in a blood transfusion during the operation. Otherwise, I don't check it intra-op. I don't really check it immediately post-op, within the hour probably. And then BID, and that can go down to once a day if needed after that. Sternal recumbency, a lot of these patients are old. They're a large breed, they're arthritic, they've got other diseases, and so after surgery, they're going to be on opioids. They just went through shock in an operation. They're not going to get up right away. And an old dog in sternal recumbency or in recumbency in general is a recipe for aspiration pneumonia, bronchopneumonia. So you want them sternal so that you can increase that tidal volume as they're recovering. And then once they're able to walk, get them walking. Now, again, some of these dogs are anemic. They have cardiac arrhythmias, right? They're old, they're arthritic. So if they have trouble walking, just to walk around the ICU unit is fine, just to get them moving. You don't want them sitting there sedentary, or if you think that they have to urinate because you've just pumped all these fluids into them, don't make them walk all the way outside. Put them on a gurney, roll them outside, then gently put them down on the ground, let them go urinate in whatever spot, and then get them gurneyed back in. So don't force the issue, but you do want to get them somewhat moving because they are prone to pneumonia. Analgesia, in the beginning, you're going to have it be injectable. Keep in mind, these are geriatric patients. They may have comorbidities that make them more sensitive to too much analgesia. So go low on the dose and work your way up. From there, you can assess their pain levels most often by palpating the abdomen around the incision and seeing if they wince, and then you can increase it from there. If you want more of a slow absorption, maybe subcutaneous analgesia might be a bit more tolerable than a rapid IV bolus of analgesia of opioids. But then once they're able to eat and drink, you're going to start oral meds in general. And then for cardiac arrhythmias, typically, if you're noticing an arrhythmia, which we'll go into this a little bit later, lidocaine bolus, then a CRI, I typically start procainamide IM, intramuscular, right off the bat. And then once I feel that their arrhythmias are under control, they're going to get off lidocaine. They don't have to be weaned off. You can wean them off, but they don't need to be. And then start oral procainamide whenever they're able to handle oral meds. Hospitalization depends on the case. And of course, you want to keep an eye on them. They came in critical and shock. They're old, so keep a close eye on them. Monitoring is a big deal, and nothing more frustrating than having a splenectomy, successful surgery, the surgeon leaves the practice because they're a traveling surgeon, and the patient isn't monitored effectively afterwards in that practice. That's very frustrating because you can catch things that are fixable, and we rely a lot on hands-on monitoring. visual, auditory, tactile. But now we've got devices like VetGuardian that are touchless. I've used this in surgery as well, or post-operative rather. And so it monitors through thermography, body temperature, pulse rate, and respiratory rate, as well as movement. It has a high definition camera. The camera can be thermography, like in this picture here, or it can be actually a video of the patient. And so it assesses all these things from a thermography camera, and it monitors this stuff. This is like an iPad or whatever, and you have multiple patients that are in the hospital that are all getting monitored through the device. They each have their own device, and it's sending it to a central location, and this is the setup for it. This is the machine, the VetGuardian. And so I do believe that telediagnostics are the future. I mean, this is where things are going, whether it be in hospital or at home. I think that devices like this are where it's at. And so if you are a kind of practice that not only cuts hemoabdomens, but other patients, pyometra, brachycephalic airway syndrome, things like that are going to need intense monitoring, but you don't always want to keep interacting with that patient because they get stressed out, or they're a bit fragile, or they're fractious, whatever it is, these types of devices are really cool for monitoring these patients without having wires attached to them. It's very, very efficacious. So I'm a huge proponent of this stuff, and if you have a practice that can justify having one of these, absolutely well worth it. And and of course contact Zomedica for more information in regards to this device. They're pretty cool. So outcome regarding hemangiosarcoma, post-operative hemangiosarcoma mean survival time. Again, these numbers, just like the incidences, are all over the place. I'm just giving you a quick rundown here so that when you're watching and listening to this, you'll have an idea of what you can tell pet owners. Keep in mind, the literature is all over the place. Your proceedings have way more detail. In general, stage 1 hemoabdomen or hemangiosarcoma 151 days survival, stage 2 107, stage 3 73, can range of course. Having stage 1 and stage 2 together, 50 to 75% within 86 days, and very few have a 1-year survival. If there's a benign disease, of course, way long survival time. It's basically curative, right? I mean, that's what ends up happening. And the survival rates: 1 year 85%, 3 year 45%, 6 year. And again, keep in mind, these are old dogs, old large breed dogs. So if you're cutting a German Shepherd and it's 8 years old, I mean, its lifespan is supposed to be in the 8 to 10 years, maybe a little bit older than that. So these chances are these dogs are dying of other conditions or life changes, and not from the benign splenic mass that was removed. Malignancy, of course, much worse. 85-day survival, 20% might live 1 year, 10% 3 years. Hemangiosarcoma, 30% survive 2 months, 7% survive 1 year. Surgery alone versus chemotherapy, 172 days, surgery a couple of months. So that's the deal. That's what you have to talk to clients about. Some pet owners are more than happy having their dog for a couple more months in good health and out of pain, out of suffering from surgery, despite the fact that the cancer has been confirmed on biopsy. They're happy with that. And others want to go chemotherapy, which can double the survival time. And for some pet owners, it's just not in the cards. And that depends. That's on your conversation with them. Complications, we kind of touched upon. Arrhythmias. The way I intervene with arrhythmias is basically 2 scenarios. Either I'm seeing ventricular arrhythmias, like in the arrows here, and the patient is clinical for it, meaning that they are tachypnic, weak, having dropped pulses, they have pallor, things like that. This is post-op. This is not pre-op. Pre-op, you're dealing with everything at once, so who knows. But post-op, if the patient is otherwise stable, are they showing clinical signs of arrhythmia? If they are, despite how bad it might be, I'm going to treat them. Or if I'm seeing in an ECG strip about 30% of the strip are arrhythmias, ventricular arrhythmias, then I treat for them. So that's my general guideline for when to intervene. Not every arrhythmia needs intervention, but those are my rules for jumping in. Prognostic factors. So these are factors that worsen the prognosis for these dogs. Acute respiratory distress syndrome or pulmonary thromboembolism, bicavitary effusion, having tachycardia and needing a blood transfusion. Well, that's kind of obvious. Most dogs who are anemic have tachycardia. Low protein, which we discussed earlier, stage 3 disease, thrombocytopenia, anemia. Having more than one gross lesion on the spleen has a worse prognosis, and having a combination of neutrophilia and thrombocytopenia that we mentioned earlier, those dogs have a higher chance of DIC. 50% will have DIC. So these are factors, again, that worsen prognosis. Again, that's more for your own edification and for the client. So just some final key points before we go into any questions. Number one, as I stressed many times, there's a lot of splenic mass literature. Your proceedings has that information in there, and so feel free, all the references are there if you want to dive in deeper. Client communication is huge. The client has to understand what the chances are of malignancy versus benign, understanding, of course, that without a biopsy, we don't really know whether or not we're dealing with cancer unless we're seeing over evidence of metastatic disease. And in that case, like thoracic mets I'm talking about, not necessarily hepatic nodules, then in that case, you're sure this dog has cancer. You have thoracic masses in addition to a splenic mass, a hemoabdomen, it's going to be cancer. Otherwise, the majority of cases, it's going to be a splenic mass, hemoabdomen, maybe it's got hepatic nodules and ultrasound, and you don't know whether or not it's cancer until you have biopsies. But the chances, based on the statistics that I mentioned, it's higher chance of cancer than not, but again, you don't know for sure, so that's very important to convey to the pet owner, which could be both liberating and frustrating, depending on the pet owner you're talking about, right? They want to know the answer. That's the way to get the answer. Splenic histopathology. Liver biopsy, always. You can biopsy a nodule or a mass that you see, or if it's safe. Otherwise, biopsy any accessible liver lobe. If you have to get more than one biopsy, you can. Otherwise, at least one biopsy of the liver is sufficient for staging purposes. And then concurrent surgical procedures, like we said, not wrong with doing it, but have the conversation with the pet owner that I have the right to abort the mission if I feel that adding on additional surgeries risks the dog's life. I'd rather get the bleeding mass out of the dog now, and then if the biopsy comes back benign, we can always then schedule a cystotomy later on, or the mammary gland mass removal later on, or whatever. PECing is a bit more difficult because we do know that without a spleen, the chance of having a GDV goes up. That is in the literature, but again, it's one of those things where we're trying to save the dog right now. What's the point of a PECsy if the patient is no longer with us? That defeats the purpose. We can PECsy them later, especially if the mass comes back as benign. But if the patient is stable under anesthesia and you remove the spleen and you're proficient with gastropexy, and I can perform PECsy in 20-15 minutes, or less, depending if I have an assistant or not. So it can be a quick surgery, but you don't want to push the limits with anesthetic and surgical safety. So you decide as a clinician with your experience and your conversation with the pet owner should probably be around that. I'm happy to take any questions. Thank you again for Zomedica for sponsoring this. If anybody wants to reach out to me, these are all of my handles. And then this gets you to the Vet Triage website, which is my company for telehealth. But thank you again for having me on, and I hope this was helpful and clinical. I'm happy to take on any questions or comments that you have at this time. Thank you.
All right. Thanks, Dr. Shoddy. We'll give everyone just a few moments. You can put your questions in the Q&A box there, and we can get Dr. Shoddy to answer those live while we still have him with us this evening. While we do that, we'll give you a few minutes. I just want to remind everybody that your CE certificate will be emailed to you within the next few days, so keep a lookout for that. It will go to the email that you used to register for this evening's webinar. So sometimes they do end up in the junk or the spam folder, so take a peek there if you don't see it within a few days. But it will be coming. Also, this evening's webinar is being recorded, so if there's any information that you missed or would like to go back and rewatch, it will be up and posted on our Zomedica website under the Learning tab. So check for that within a day or two, and you'll be able to go back and watch anything that you may have missed this evening. So with that, Dr. Shoddy, let's get right into the questions here. First one that I saw that came through, any words of wisdom for us single doctor practices? This one says, I tend to refer these cases out for surgery.
Yeah, so number one, you can perform these as a general practitioner. You don't have to be board certified to perform these. You have a frank discussion with the client saying, typically these are referred to the specialist because you require 24-hour monitoring and they have all the fancy toys. There will be probably a considerable financial commitment to that versus what a general practice will charge, but you're paying for that specialist ability as well as the 24-hour monitoring in ICU. And for some clients, they're happy to drive the distance and pay that money and do it. For those who don't have that ability, whether it be financial or geographic, whatever it is, then doc, you're welcome to try these. I usually recommend the standard approach of if you have the opportunity to practice splenectomies on a cadaver, or either that you collect from a source or you euthanize the pet and you get owner permission to perform this, then practice the splenectomy. If you have a splenic mass in a dog who's stable and not showing clinical signs, you found it incidentally in a geriatric animal, you talk to them about the specialist, they decline it, they trust you, you tell them, look, I haven't done this before, I've done a few, but just realize that, and they sign off on that, then so be it. Do your best, have at it. It's best to do a splenectomy under controlled conditions where the pet is stable, there's no hemoabdomen, it's an incidental finding. Those are the best surgeries. You can take your time, there's no rush, and at that point it's just any vascular, it's like a glorified spay. You're just like getting more vessels for that. And then as far as post-operative care, actually real quick, you might think, well, I'm in surgery, it's only me, I don't have an assistant scrubbed in. As a surgeon, I have bowel floor retractors, abdominal self-retraining bowel floor retractors. So if you have those, definitely use those. I usually also have like an intern or resident with me or a scrub nurse with me so they can retract things and help hold things. If you don't have that, especially in a situation outside of a hemoabdomen, if you have bowel floor retractors, that's very useful. Otherwise, you don't really need them, especially if you're not dealing with a hemoabdomen. You can exteriorize the spleen in its entirety and take your time. Otherwise, a hemoabdomen, you're going to need a suction unit to remove that blood, and you're probably dealing with a spleen that's actively bleeding, so you want adequate visualization. So maybe you can suction out that blood sufficiently enough to exteriorize that whole spleen, and then go through with the splenectomy. It'll be a messier surgery, you'll be sweating a bit, but you can do it alone. When I've been on call, I've done the whole thing alone, but I also have bowel floor retractors and I have ligature, so I can go through quickly. So, and then for post-operative, the client has to understand that either you can or cannot handle that case post-operatively, depending on how critical the patient was, or if it's a matter of life and death, guys, and they don't really want to euthanize, but they understand taking that dog home that night post-operatively, day one, is a risk, and this patient really should be surveillance. I'd rather have the pet owner give it a try. Cut the dog, do the best you can, stabilize them. If it has to go home at 5 p.m., goes home at 5 p.m., have them come back the next day with the patient if you're open the next day, and continue monitoring. So I'd rather have that than a dog just euthanized because there was no ability, or there was no ability for aftercare. Some care is better than none. And so that's a long-winded answer to your question. It's not a hard no. It's just all about client communication and making sure that your skills are there through practice. I will recommend cut these dogs early in the week so that you have the whole week to have them come back. Cut them first thing in the morning so you have the whole day to monitor them, if you have that luxury to plan it out that way.
Okay. Next question. How often does the splenic torsion result in hemoabdomen?
Maybe in my career, I've been a vet since 2006. I've seen maybe 2 splenic torsions in my career, and they were both bulldogs, English bulldogs, which are the standard breed. Bulldog breeds are the ones that are prone to it. So I haven't really seen that. So not common at all in my experience with it, but it's a possibility. I only mentioned the torsion because if you do happen to see it, I don't want people unraveling it. So that's the only reason why I even mention it. But the chance of somebody seeing in their career, especially if they don't cut these a lot, is probably not very common. But I don't. As far if you're looking for an actual percentage, I don't know. I did not do a literature search specifically on torsions, so I don't know if there is a publication on that number. But they're so rare in general. I'd be pleasantly surprised if there was a paper on that.
Okay. Next one is just a comment. Excellent presentation. Thank you for that.
Thanks.
And we've got a few more minutes. So if anybody else has a question, we've got some time while
I can make a comment on oral analgesia. Maybe some are wondering. So, when I talk about transitioning from injectable analgesia to oral, I'm talking about probably gabapentin and or tramadol, depending on what the pet can handle, what it needs. I don't know about newer drugs, unfortunately, that are out there that may be accessible for oral administration. But as far as non-steroidal anti-inflammatory drugs, which a lot of these dogs might be on if they have arthritis, I'm not going to use those in these cases because they have a tendency to affect hemostasis in general. The same way orthopedic surgeons usually want the non-steroidal anti-inflammatory to be discontinued like a week before orthopedic surgery, right? Because we do see increased bleeding in surgery when a dog is on NSAIDs. So even though it's a great analgesia, anti-inflammatory, I don't think in these cases I would do it. Do some surgeons administer NSAIDs? Probably, but I was referring more to gabapentin and tramadol to stay away from that side effect. So if anybody's wondering that, that's my thought there.
Okay. We've got just another minute or two. We certainly want to be respectful of everybody's time, but we have just a few more minutes. So we will give it just a little bit longer.
Sure. Thank you. And for the sole practitioner, feel free, this is a bit off topic, reach out to me about vet triage because we have 24/7 video telehealth available. So you can partner with our platform and our doctors can be accessible. Your client can call in, they pay a small fee, talk to our doctors, and that way you at least get some veterinary access after hours, especially in those scenarios where you're cutting a case that you can't keep in the hospital and can't go to specialty center. Feel free to reach out to me about partnership and we can give your clients access to veterinarians, live video, 24/7, English, Spanish speaking. So feel free to reach out to me.
All right, good to know. Well, Dr. Shoddy, I don't see any additional questions that come through. And like I said, I want to be respectful of your time and everybody who joined us this evening. We are grateful that you took time to do so, and we hope to see you on another Zomedica webinar in the future. Dr. Shoddy, I look forward to seeing you somewhere live and in person soon. And with that, I will give everybody back your evening. Have a great rest of your week, everybody.
Thank you.
Bye, guys.
Bye-bye.